I don't see that Beth has logged in yet. Let me scroll and make sure I didn't miss her. People are still trickling in. I don't see Beth yet. So as soon as she logs in, I'll let you guys know and we will take roll.
I like cinnamon. If you're going after rolls.
I do as well. All right, she's logging in now. Beth, I believe you're muted.
Good morning.
Good morning.
Sorry, I was having trouble signing in. My computer told me I had to update suddenly. Okay, so let's go ahead and call the meeting to order. Erin, would you mind taking the roll call?
Yes, ma'am. I have Beth.
Here.
Nina.
Here.
Susan.
Here.
Dr. Roberts. Dr. Bobrowski.
Here.
Dr. Compton.
Here.
Dr. Mueller. Dr. Gupta.
Here.
John Dadds. Oh, we've got some people in the waiting room. Let me get them admitted. Dr. Hannah.
Here.
Barry Martin.
Here.
Kent Gilbert. Mackenzie Wallace.
Hi, I'm here. Sorry, it took me a second to get off mute.
That's okay. Anissa Franklin. Dr. Schuster.
Here.
Brian Proctor. Peggy Rourke. Eric Wright.
Sounds like we have some people missing. Do we have a quorum?
I have 11 counted in, so we should be good to go. Yes, ma'am.
Okay, thank you. Okay, then first up, could we have a motion to approve the minutes from our last meeting and the previous meeting, since we didn't have a quorum at our last meeting?
This is Susan Stewart. I approve that. Make that motion.
Thank you.
I'll second that motion.
Thank you. Any discussion? All in favor, say aye.
Aye.
Any opposed? Okay, minutes are approved. Thank you. First up on old business. And I understand the commissioner is not able to be with us today. So Veronica Cecil is here in her place. Is that right?
That's correct. Good morning.
Good morning. So under old business, is there any update on when CPMs might be included for reimbursement with Medicaid?
We still have not determined a date as to when we're going to make that decision or move forward on implementing that. So unfortunately, we don't have an update beyond that.
That on the agenda. Thank you. And then this is just a reminder, this next item, update on missed and canceled appointments. How is reporting going? Is there a common thread as to why patients are not showing up for appointments? And the next update on that will be in March. We agreed at last meeting that we would do that every 6 months. So we'll be looking forward to hearing about that in March.
Yeah, and Dr. Parton, just I wanted to let you know that we're creating a dashboard that's user friendly that we anticipate being able to post on our website and share regularly with folks. So definitely by March, I think we'll probably be in a really good shape and something that trends so we can show the historic of where things are. And we're going to break it down by provider type, by MCO. So we're working on that right now.
Great, thank you. Okay, and then again, this is just an update here on the hepatitis C prenatal screening, number of cases, number treated, and the next update on maternal child health was to be at this meeting, but will be postponed to January to 23. Next up is the status of the Anthem MCO.
The status is there are no changes. The lawsuit is still pending, so there are no changes at this time.
Okay, I'll just keep that on the agenda. Okay, and then ramifications of the abortion bill related to Medicaid.
Dr. Parton, I think given the election last week, we don't really know what's going to happen with this yet. I'm fine tabling it until some new news comes out about it.
Okay. Okay, thank you. I'll just keep that on the agenda then. We are moving right along.
Beth, did you skip over item C? The update on reimbursement for multiple visits.
I did. Thank you. So that is update on reimbursement for multiple visits on the same day. Where are we with that?
And Dr. Parton, if you could please clarify, and I apologize for not for following up with you prior to the meeting, but is this the primary care tax recommendation to allow FQHCs and RHCs multiple visits in a day? Or is this related to being able to bill for providers being able to bill for multiple visits?
This is related not just to RHCs and FQHCs, but all providers being able to bill for multiple visits for instance, primary care, and then the patient has a specialist on that same day.
Right. So we're not aware of any issues. I think at one time we had an edit. There was an edit that prevented that, but that edit was changed, I think, quite a while ago. So I think at this point, it's if there are providers with a problem related to this, maybe they could send us examples, but I'm not aware of current issues.
Okay.
Now, the FQHCs and RHCs is a very different thing because it's about them being able to get more than one PPS in a day. That evaluation is still ongoing, and we'll work with the primary care TAC on that. But as far as providers being able to bill for multiple visits, I'm not aware of any ongoing issues.
Okay, well then I'm going to go ahead and keep that on the agenda related to the RHCs and FQHCs.
Well, so our plan is to, once we're finished with our evaluation, is to present that to the primary care TAC and have conversations with them, just to let you know that probably something would come back up through the primary care TAC related to that.
Okay. I guess I have an interest in if it comes up through the TAC, it may not be public through the MAC, and I'd like that information to be shared publicly through the MAC.
Okay. I would request that maybe we change then the item to be specific to FQHCs and RHCs, and then that might help us then track it a little better.
Okay.
Thank you.
Okay. Any questions from the MAC regarding United Healthcare and the WellCare presentations from the last meeting? Okay, I do have one item, and I brought it up at the last meeting, and I'm going to bring it up again with United Healthcare. This issue has been remedied with Molina Passport, but not with United Healthcare, and that is reimbursing providers with a credit card. This is causing providers to have to pay a fee in order to be reimbursed, and it can get into significant amounts when you're paying those fees. And so I would like United Healthcare to speak to that, if they would.
This is Krista. Hopefully you can hear me. I'm not seeing myself, but can you guys hear me? Can you give me a thumbs up or something?
Yes.
Perfect. Unfortunately, my COO, who is closest to this issue, is not available today. It is something that we were not fully aware of, so thank you for bringing it to our attention. My understanding is that we are still, I can follow up with you offline to get the information from my COO to you in terms of what the specific situation is or was. It was some type of program rolled out, and I think it's, I don't want to misspeak, so I'll wait and get the details from him and follow up with you.
Okay, and it's not just me, it's all providers. We're receiving a credit card reimbursement, and we have to put that through our credit card machine in order to be reimbursed. And the credit card processing companies are charging us a fee.
Yeah, and I believe our preference is to do an electronic funds transfer, and the credit card, virtual credit card option was made available to providers that were not interested in EFT and were receiving paper checks, but that's about as far as my knowledge base is at this point on this particular topic.
Okay, so when you call to try and get that changed to EFT, you're put on hold forever, and we don't have time to spend.
Do you know what number you're calling? Because that wouldn't be what we're seeing in our dashboard. So I want to follow up on the.
I don't know offhand what number that is, but I just would like it fixed. And
if you want to follow up with me and let me know what number that is that you're calling, because when we look at our service dashboards, we're not seeing long hold times or call abandonment on our provider service lines. So I want to investigate because you're doing something different.
Okay, would you just send me an email after the meeting, and that way I'll have your email address and we can communicate that way.
Sounds great. Thank you. Thanks for helping us.
Okay, thank you.
Figure it out.
Dr. Barton, I got a comment there. Just, I know dentistry had to pass a bill that back in the spring, it was House Bill 370, and it passed through the House and the Senate unanimously on just that issue for the insurance companies really to not use that form. But I think in their contract language, they were putting it as an option for a provider to use. But most people are just like what you're saying. It costs anywhere from 3 to 5% just to get your payment. And a lot of times the insurance company and the finance people were splitting that fee. But we had to pass a bill to get that straightened out.
So was that bill just related to dentistry?
I believe so. I don't think any other provider type was added in on that.
Okay.
Oh, sorry. Yeah. Okay. I thought I was on mute, but I'm not.
Okay. I just got a message in the chat that said, yes, it was just. Okay.
Dr. Parton, I think your concerns are valid, and we'll go back to the MCOs and ensure that that's just an optional reimbursement mechanism, and they should not, that should not be the primary or initial reimbursement mechanism for providers.
Okay, thank you.
Beth, this is Sheila Schuster. Could I ask a question of Deputy Commissioner Cecil about the multiple visits on the same day? I just want to be sure, because this happens to behavioral health all the time, Veronica. You know, they see their primary care provider early in the day, and then they have a behavioral health visit later in the day. And that has been a problem. It was a race to see who was going to get their claim filed first, because that was the one that was going to get paid. So am I understanding that the edit's been fixed and that should no longer be a problem?
Yes, if you have recent examples of that, I would like to see them, because there should be nothing that prevents multiple providers, especially, you know, different NPIs and different services to be denied. And there could be other reasons for denials, but
yes, yeah, I understand that, but we will certainly let the behavioral health community know that, because that's been a problem for years. So appreciate that very much. Thank you. And thank you, Beth.
You're welcome.
Okay, so do I need to do something with United Healthcare, or is Department of Medicaid Services going to do something about that?
We'll take that back, Dr. Parton.
Okay, thank you.
Yeah.
Okay, next up is update from Commissioner.
Just a couple of things. One is the Commissioner, I believe Commissioner Lee committed to providing a Medicaid budget update. So I do have a short presentation for that, but wanted to address a couple of other things and provide an update on them. One is House Bill 525 passed earlier this year. It required the department to cover community health workers. We've been doing a lot of work on that, including stakeholder engagement and meetings with Department for Public Health. And our goal is to file a state plan amendment towards the end of December. We will comply with 525, which designated certain provider types that we're supposed to reimburse for CHWs in those provider types. So we are working on that, and we'll most definitely share, once we've got the public notice prepared, we'll share that out to all the MAC and TACs, and it'll be posted on our website. So look for that probably, you know, mid to end of December. We expanded dental, vision, and hearing services. We added additional services to the adult benefit that mirrored a lot of the coverage that we had for children. And we're excited about being able to increase access to our adult members, and we are in the process of creating frequently asked questions to send out so people understand what those services, a little in more detail about what those services are and any limitations, because there are some limitations. But that is effective January 1, 2023. We understand that there might not be an immediate uptake to those services because we're still finalizing all of the codes and reimbursement, and the systems have to be updated, and we're working with the managed care organizations about what that coverage is. So we know there's a lot of questions. We're really trying to work very diligently to get those addressed and get something issued out to everybody so you all can understand what those additional benefits are. We did not receive the 60-day notice from CMS that the public health emergency would end on January 11th. What that means is that we can expect another extension, and that would get us into mid-April. That's, you know, a bit of a relief to states. That it gives us even more time to be prepared. Kentucky's in a pretty good situation in terms of we've been primarily focused on making sure our systems were updated to unwind. We've been working on our communication plan and training plan to make sure that we're notifying everyone. And by that, I mean providers, stakeholder, you know, advocacy organizations, community-based organizations. We are concerned about workforce, our contact center. We do have, I believe an hour wait time at times on our call center. So adding unwinding and redeterminations on top of that, we're very concerned about that. So we've been very focused on trying to recruit and retain in that area. But a lot of our Department of Community-Based Services social workers have never done a redetermination. We have a lot of new staff, and connectors who have never done a redetermination. So we're really focused on making sure that people are adequately trained and understand what to do. Our goals there are to prevent unnecessary administrative terminations. In other words, if somebody is Medicaid eligible, but for some reason was unable to return that documentation that we need, that we might have asked for in the allotted time, we want to prevent them from being terminated. So we're going to do a lot of work, including through our managed care organizations, to do outreach to individuals that we know are in that situation, that they're being required to return something so that we can do the redetermination. The good news is that our system that we've really been working on and focusing on is about at an 85% passive renewal rate. And what that means is it does a really good job of going out there and pinging the federal hub and other databases to verify information so that individuals don't have to take any action. So we have one of the highest rates in the nation. Our system's doing a really good job of verifying that information. So what that means is, you know, it'll really just be a smaller part of the population, not all 1.6 million. That it'll be a small part of that population that we'll really have to do an active redetermination for, and we'll have to engage to make sure that they're providing the information that we need. We also understand that folks are going to be ineligible based on income, and what we want to make sure is that they smoothly transition over to other coverage, such as a qualified health plan. In looking at our system, it appears that there is around 80,000 people that would likely qualify for the APTC, the Advanced Premium Tax Credits, in a qualified health plan that helps offset costs for those plans, that they're eligible for those. And so we're going to work to try to make sure that individuals understand that that option is available to them, and help and work with them to do that. So our focus is keeping people covered or getting them transitioned to other coverage and to be in compliance with CMS. So that's an update on unwinding. But if it's okay, I will move. Oh, Dr. Bobrowski, I see your hand up.
I was just going to let you know, I just sent a list of 25 questions plus sub questions to the commissioner last night. So I know she hadn't probably had time to read them this morning, but as with dentistry, there's going to be a lot of concerns and working through the process type thing. And
yeah,
we'll get there. We'll do it. I just noticed on one of the codes, this was supposed to be for adults, but I noticed there was a code or two in there that was specific for children. So we might need to, we'll look at all of it, but I just wanted to let you know I did, and I apologize, I didn't copy you on that. So
that's okay. She copied me and she's already sent it over to our team and they're working on it as we speak.
Well, that's a great bunch to work with, I tell you.
Thank you. Thank you. Susan?
Sorry, I had trouble with my unmute button. My question is, have you all received notification on approval from CMS regarding EVV?
Not that I'm aware of. Pam Smith, if you're on.
We have not. They did ask us a couple questions and we have sent that back to them. They were really, it was clarifications. It's not ones that I'm concerned about. So, but we have not received the official approval back, but they did let us know that it would likely be December before we would get the final approval of that GFE. Yes.
Thank you.
Mm-hmm.
All right. Any other questions before I dive into budget? Okay. All right. I'm going to attempt to share my screen, which is a little difficult for me in Zoom than it is in Teams. So we'll see here. Can everybody see that?
Yes.
Excellent. All right. So this is part of a presentation that Commissioner Lee and Steve Bechtel presented to the Medicaid Oversight Advisory Committee, and the full presentation is posted on their website. But we chose a few, the commissioner chose just a few slides to go through to give you guys an update on what that budget looks like. So I'm going to jump to this slide, which shows you that our actual expenditures in 21 and 22, as you see, there's about a $500 million difference between the two, 14.3 and 21 and 14.8 and 22. Our budget for state fiscal year 23, which runs from July 1 of 22 to June 30th of 23, is $15,272,000, and for 24, because it's always done on a biennium, is $15,847,000. So that's and we'll share these slides with you after the meeting. But that's just a kind of a snapshot of what those budgets, what that budget looks like. So speaking in terms of state fiscal year 2023, these are our expenditures to date. I always, the federal and the state, I really just try to focus on the total for you all. But as we mentioned, our enacted budget was $15,272,000. Right now through October, we've spent almost $5 million, $4,970,000, and that represents about 32% of our overall budget. So, you know, we're tracking. So this is a quarter in, and you know, we're Steve Bechtel might disagree with me, but we're tracking a little bit on budget so far. So this big beautiful pie is a Medicaid budget, looking at it from all the different programs. What you see is the largest there, which is managed care, and they serve over 90% of our population. So almost $8 billion there. So that represents about 79% of our budget for, again, keep in mind, for over 90% of our population. So that makes sense. Fee for service is a little over $3 million. Even though our fee-for-service population is a little less than 10%, it does encompass a little over 20% of our budget. The big piece for the fee-for-service comes from our 1915C waivers and our Money Follows the Person transition program and home health, and that's the alternative community care. They're represented at $1.1 million. Our nursing facility is the other big piece to that, and that's over 1.2 billion. The alternative community care is 1.1 billion and nursing facility is 1.2 billion. So that breaks down where our costs are really going. We've started to break out and show folks that over 22% of the managed care budget is actually directed payments that is in state statute. And so, these are mandated for us to pay. Right now, the big pieces of that are our hospital rate improvement program. As you can see, total to date from state fiscal year 2020 to now is over $2.2 billion. The university directed payment is the university hospital, which is similar to the hospital rate improvement program. And that a total over those a little over three fiscal years is $3.8 billion. And then we have a fairly new ambulance provider assessment program, which has increased reimbursement to our ambulance providers across the state, which started in state fiscal year 21. And right now we're at $82.5 million for that program. This is looking at our waiver expenditures. We do have 6 waivers. So this is just showing across the state fiscal years where we are in spending for those different waiver programs. There was we noted about a 9% increase from state fiscal year 21 to 22 of about $90 million. We did want to note that it does show a decrease in brain injury, but that was due to decreased utilization as a result of COVID.
I'm on a MAC meeting. Can I call you back a little bit?
Early part of 22. Oh, I'm sorry. I did want to note, sorry about that, that for the waivers, we did submit a spending plan to CMS to utilize those increased HCBS FMAP that was under the American Rescue Plan. And that would provide a 10% increase in rates across all waivers. And that's in our budget, but we're waiting for CMS approval still to do that.
Excuse me, Veronica, I don't know how to raise my hand.
Sure.
Can you go back to the 1915C waivers? Because I had a question I was going to ask. I've been hearing from providers of those services about the difficulties that they're having, and I know you've been hearing about it, keeping their doors open and providing services due to tremendous staffing difficulties. We know that House Bill 1, the biennial budget, had language directing that 10% rate increase. And DMS has testified at legislative committees about this issue. Pam Smith sent a letter to waiver providers on September 16th indicating that you all had submitted the plan and will expedite reimbursement, which I think is what you just reported. That was 2 months ago, and people are really getting fairly desperate at this point. So on behalf of the HCB waiver providers, I'm asking, what's the status of the rate increase? What communication has been received from CMS? Are there any barriers to implementation? And what do you see as a really accurate, if the most accurate projected time frame that you can give us for reimbursement of those adjusted rates to begin? Thank you.
Hey, Pam, are you able to address those questions?
I can.
Thank you.
So we have not received the final approval from CMS. They sent us some questions, as well as pointed out again to us that in order to use those funds, we have to have an approved rate methodology in place, which is the rate study, as you know, is in progress right now and is targeted for those. We previewed some of the rates with some groups yesterday, and we'll be ready to, after some small changes, present those, begin amending regulations and the waivers in early 2023. So while we cannot, the rate will go back retroactive to July 1st. We can use Appendix K to do that. We cannot use the ARPA funds to pay for those rate increases until until that rate methodology is in place and approved by CMS. However, there are some, right now, and we're evaluating whether we need to expand it to some additional services, but a large portion of the HCBS, the services that are, the direct support professionals that are not the clinical services, are able to request up to a 50% increase right now through Appendix K. So they're even able to request more than that 10% right now and be billing that. That was retro back to January 1st of this year. And we do have several providers that have taken advantage of that and are doing that, or using that, that rate increase.
Thank you, Pam. Are providers broadly aware of the direct service provider 50% increase?
I believe they are.
I didn't see that in your letter.
We had done some aggressive communication around Appendix K when we first put that in. We will be, and I can target kind of a section of communication that's going to be going out soon with an update of where we are on the rate study. So I can reiterate that, Dr. Schuster, and let to make sure that people understand. We also are going to, we've talked about, it's going to be important as we move forward with the rate study, and just, it's been a while since we've had some of those larger stakeholder sessions where we basically just kind of held open office hours and people could come in and ask questions. That we are going to target starting some of those in January, once we get through the holidays and have a better idea. The timeline is a little more firm on the rate study completing.
Pam, this is Rick Chrisman. As you know, we talked about this very issue at our TAC meeting, but there are some services that still have not been eligible for that those rate increases through Appendix K. Wouldn't that include day training and like residential 2 and perhaps some others?
So day training, the day training and adult day providers for this version of Appendix K were eligible for retainer payments, and it was for three retainer payments. Those are targeted to go out next month at the latest, and it'll be all 3 of those retainer payments. And then we can evaluate, and Rick, I think this is what I mentioned in the TAC, with my leadership and additional staff, whether based on the timeline for the rate study, if we need to do a different amendment to Appendix K, or if that needs to change based on what the timeline looks like for the permanent rate increases to be put into place.
I realize it's very complicated. Tell me again about those retainer payments that are pending.
So all of the ADTs and ADHCs that applied for the retainer payments, we are in the process of doing the final quality checks on who meets that criteria. And I'm sorry, I don't have it in front of me, and I don't want to speak percentages because I will get it wrong without having it in front of me. But we're doing the quality checks to make sure that everyone that applied met the criteria. And then we will send out, they were eligible for three of those retainer payments. So it's basically 3 consecutive months of those. What it would entail would be three consecutive or 3 months of reimbursement in those retainer payments. And that is targeted to go out before Christmas next month.
Okay, and this is going to compose all of my presentation anyway, but Sheila, for you to know, I guess the rates that are legislatively mandated through HB1 will be the floor, correct, Pam? And then the rate study, they could exceed that.
There are no rates that the proposed increase through the rate study is below the 20%, which is the 10% for fiscal year 23 and the 10% for fiscal year 24. A lot of the services, the majority of the services are receiving much more, or are, I should say, proposed, because, you know, again, these all have to go through all the formal approval processes, but the proposed new rates, the majority of them are well above that 20% mark.
And that the new rates that are going to be forthcoming from this rate study may be in play by about this time next year, would you say?
Yes, that is the target date to get, you know, realize we're dependent on legislative review timelines as well as CMS, you know, CMS's timeline for reviewing them. But the plan would be that we could match up the end of Appendix K. So when, you know, the increases through Appendix K, when that ends, that the new rates would be ready to take place so that there wouldn't be a gap.
Yeah, so answer your question, Sheila. It's very complicated, but they're working on it. Thank you.
I know the ABI folks belong to the BHTAC. There's two questions in the chat, Pam. One, can Appendix K be sent to the MAC members? I think that was from Sue Stewart, maybe.
It can, and it's I can get that to Aaron and we can get it out, or it probably will be easier for me to have Aaron send the link, but it is out on the website, okay, as well as all of our, we recorded our sessions where we went over those. So those are also, the recordings are available as well.
Oh, that would be great. And then Amy Stade has DMS testified in July that Appendix K had already been amended to reflect the HB1 increases. What happened?
We have to get CMS approval.
Right. So there was so Appendix K was modified to allow for increases that are even, and that was done prior to House Bill 1 even being approved. We cannot do anything with the House Bill 1 increases until we have final approval. And again, the rate that the providers are able to get through the Appendix K amendment is 50%. So it's much more than the House Bill 1 increase.
Okay. I think I'm getting an intense lesson here on some of these ins and outs, but I appreciate your willingness to communicate all of that, Amy, and I mean Pam. And I just want to reiterate that these are our most vulnerable people on these waivers.
Absolutely.
And we just worry so much about whether you know, people are going to get services. I see Dr. Gupta has a question also. Do these rate increases only apply to these specific Medicaid waivers? Yes. Or does it also include the common E&M codes we use in the clinic?
So the rates that were in House Bill 1 are specific to 5 of the HCBS waivers. Yeah. Model 2 was not included in those increases. And the rate study that I've been referencing also is specific to it's specific to all of the 1915C waivers. So all of the conversation and the speaking that I've referenced has been directly related to the 1915C waivers.
It might be helpful if we go back and maybe prepare a couple of slides that really talks through. We've done a lot in rate increases for the waivers throughout the COVID-19 PHE. So I think it might, maybe what we can do is try to distill that information down a little bit easier to understand and show across what we've done throughout the PHE and then what's pending.
We actually have one in draft right now, Veronica. So
excellent.
Perfect idea. So
yeah, and we'll get that out because it is confusing. And yeah. I assure you, if we could wave a wand and make CMS make a decision when we want them to make a decision, we do it. But we are at their mercy.
Right.
We follow up regularly on this. They are well aware of our desire to, to get this implemented, especially since it's in the budget. So I can assure you we're working on that.
And one more thing, and Pam, it'll be the case that in regard to the rate increases contained in HB1, the 20%, they will be paid eventually retroactive to July 1st.
Well,
correct?
the 10% would be, because remember it's 10%.
Oh, the 10%, of course,
10%
yes.
each fiscal year. We referenced in the rate study the 20% because, the rates will be in place for longer than just that period of time. So
you are correct.
Yeah, I love the idea of a couple of slides, and if you could put some, some timeline in there when you do it, Pam.
Absolutely. And
I know it's up in the air because of CMS, but post CMS, pre CMS approval, post CMS approval, and what you see is kind of the bottom line, and the things that are retroactive would be helpful.
Absolutely. We will do that because it's a lot to try to unpack and to try to understand, even with working in it every single day. So we will do that.
All right. Thank you so much. I appreciate
You're
it.
welcome.
Thank you for your questions, everyone, and for weighing in, Chris. Appreciate it. Rick.
I'll put the agenda for the next meeting, so we'll have those slides.
Excellent. That sounds great. So just a couple more slides, and this is non-appendix K. A couple of the other, what we wanted to show for the public health emergency impacts to our expenditures, and they were really related primarily to nursing facility and hospital. We added a $29 add-on for nursing facility. We also added $270 per COVID positive patient. And we increased the bed reserve days for them, which resulted in an increase in expenditures. And then we did increase the hospital DRG by 20% for discharges. So that's that. And then a couple of things that, have impacted our expenditures, and that is continuous enrollment. We're having to keep on. Right now, we're up to about an increase of 375,000 people. That we have increased from pre-COVID-19 public health emergency to date. When we don't know, again, until we go through a redetermination, how many of those folks are going to maintain Medicaid eligibility, and that's something we'll find out over the 12 months as we unwind. But the 6.2 FMAP that was afforded to states for that continuous enrollment, it has helped us manage that budget increase. So we keep reminding CMS that we appreciate that and would like to continue that as long as possible, especially through unwinding. Some of the other flexibilities, as you all are well aware, we expanded telehealth and we increased the limit on inpatient beds to 25 for critical access hospitals. We waived certain requirements for durable medical equipment so that people could get access to their DMEs. And we expanded settings for adult day training and adult day health to be provided in home. So several things that we did over the course of the public health emergency. So that is just a couple of slides I wanted to go over. Are there any other questions?
Veronica, on some of those optional things, what are we doing with those? Are we considering those, especially like telehealth? I'm sure Sheila and others will chime in and say,
yeah, telehealth isn't going away. So we, we filed a regulation and really cemented several of the flexibilities that we have had in place in the COVID-19. The only thing that we don't have control over is platform. And right now under the PHE, we have available, providers have available several platforms to do that telehealth. Once PHE ends, we have no flexibility to continue those. But, we plan a lot of communication around that to make sure providers understand what they can and can't do once the PHE unwinds. But, we did take a lot of the flexibilities and implement them already.
Yeah, and I would say that the BH TAC had requested an FAQ on telehealth. We had a briefing on all of the reg changes, and that document is out there. It's excellent. It's a FAQ on the current status of of telehealth in the Commonwealth. And then there's also a kind of a flyer that goes along with it that could be helpful for you to distribute to your staff and even to patients. I don't know where those are housed. I guess someplace on the DMS website, Veronica.
Yeah, I'll double check to see if they're on our COVID-19 website, but if we haven't, we'll resend or send to the MAC and the tags to make sure they have it.
Yeah, because it's really an excellent piece on telehealth.
Thank you for that, Dr. Schuster.
Yeah.
Thank you.
And that is, I believe, completes the commissioner's update unless there are any other questions.
Okay, thank you. So next up is reports and recommendations from the tags. And first up is behavioral health.
Thank you very much. The Behavioral Health TAC met via Zoom on November 3rd. We have a new voting member representing the Brain Injury Association of America, Kentucky chapter. We had a quorum. We had DMS and Department for Behavioral Health representatives, and all 6 MCOs were there. We had great interaction from Justin Dieringer over at DMS, who told us that they were creating the dashboard that Deputy Commissioner Cecil just mentioned to you. So we're very excited about that. We have been wanting to see how many of the reports to the no-show portal are coming from behavioral health providers, because we really want to up that. So I think he's hoping that January will be a go live on that. We continue to struggle with coverage for people who have who are dually covered, not so much with Medicaid and Medicare, but for those who have Medicaid and a commercial insurance. So each of the MCOs told us whether they have a bypass list or not. I'm happy to report that Aetna, Anthem, Humana, Passport by Molina, and just recently WellCare all have bypass lists. United is working on theirs. We had people from each of the MCOs put their contact information in the chat so that the providers could contact them. But Deputy Commissioner Cecil requested that they post those bypass lists in their provider portal, which we certainly seconded and were encouraged by. She also said that DMS had met recently with the MCOs about trying to create a uniform bypass list that would be used by all of the MCOs. So we feel like we are inching closer to a resolution to this. It just kills me that people who have coverage from 2 different sources have a harder time getting their services reimbursed than those who just simply have Medicaid. The Credentialing Alliance being created by the Kentucky Hospital Association and Verisys should go live by the end of November. We're excited about that. We still have a number of problems about the number of MCO audits of providers, and Jennifer Dudinsky of DMS gave us some feedback about targeted case management should only have a look back period of 1 year, and she's available to receive complaints. Leslie Hoffman updated us on the status of the SUD waiver and the reauthorization of the 1115 waiver, which is now called Team Kentucky waiver. We looked at the work of the EMS task force, which is one of the issues that we've been following. This is the problem of people with mental health issues not being able to get transportation from a hospital that doesn't have a psych unit to a hospital that does have a psych unit. And I'm not sure that the task force is going to come up with a firm recommendation on that. we do have a series of recommendations that are all tied to the same issue. We recommend that Kentucky Medicaid prepare a document listing all benefits and services for mental health provided to adults and children who are Medicaid members, similar to the document being prepared with the primary care TAC, listing all substance use disorder benefits and services. Secondly, following the completion of the first document, the DMS would instruct all of the managed care organizations to prepare and submit information to DMS about their benefits, operations, and value adds regarding behavioral health services, so that DMS can create a side-by-side comparison of the MCOs as they've done for maternity benefits. If you all have seen that, I think it's a very helpful tool for consumers to switch MCOs or to pick an MCO if they're first becoming eligible for Medicaid. This would include a variety of information specific to children and to adults, various populations, whether they have add-ons such as cell phones, what incentive programs are in place, apps, transportation aids, medication refill reminders, criteria for case management, communication with primary care providers and behavioral health providers, and where and how prior authorization is used. Upon receipt of this information, the DMS will prepare and post this side-by-side comparison and make it available to providers and members upon its completion to be updated prior to open enrollment each year. And finally, that both of these documents be made as accessible as possible in terms of format, vocabulary, font size, and available in Spanish and in all other languages in which DMS issues written materials. Our consumer rep on the PAC emphasized the importance of making the information and comparison chart as clear as possible without adding to members' confusion. In that vein, we suggest that materials be reviewed by our voting members and also by the voting members of the consumer TAC before being published and disseminated. Our next meeting will be January 5th via Zoom from 2 to 4. And I'm available for questions. Thank you very much.
Thank you, Sheila. I would like to make one comment on something that you touched on, and that is the audits. Recently, we had to send records on patients, multiple patients, requested by some of the MCOs, and they don't have the ability for us to send those records electronically. And since most practices now are using electronic health records, we have the capacity to send records electronically, but the MCOs don't have the ability to receive them electronically. And with the request going back so far, it's tons of papers. So to fax it is unrealistic because of the time that it would take to fax that many papers. So recently I had to mail records, and it cost $55 to mail the records. And so that's a burden when you've got multiple MCOs requesting records and no ability to send those many records, because some patients are seen every month. And so that's a lot of paper. So I would like to speak to that and say that maybe the MCOs develop a capacity to receive those records electronically to ease that expense on practices and to just ease the work burden of printing out. I mean, it's not only the postage that you have to pay, but you have to pay for the paper and the ink to print those as well, which is becoming more and more expensive, as many of you who have practices know. So I guess I would like to add that question to the MCOs about being able to receive those records electronically.
Chair Parton, if I may, Stuart Owen with WellCare. And I'm curious about the specific audit, because I know like our medical record audits, we allow electronic. We also volunteer for staff to go to the office. We also allow for staff to remote in, if the provider gives permission virtually to give them remote access control. So I definitely know that. I know that's for our medical records quality audits, HEDIS audits. So I know that's an option for that. I don't know if that's exactly the specific audit we're talking about here.
Well, that would definitely be helpful. If you could send me information about
sure
that would be helpful.
Yeah, will do.
And if the other MCOs can offer something similar, that would be helpful, or allow us to send the records electronically.
Sure. This is Dr. Kanner with United Healthcare, and we also have electronic capabilities to be able to send information, especially around HEDIS and other quality measures that we're asking for. But I'm happy to direct you to more specific people on our team who can help with that.
Okay. If I think it might be helpful if just the MCOs provide us that information, maybe send it to Erin and she can.
Will do.
Thank you.
Excellent addition, Beth. Thank you. We've not had that specific one. We've been talking mostly about the quantity of, and sometimes the extremely short turnaround time. And we have got a lot of support from DMS, and I will pass this along to the MAC members, that providers can always ask for an extension of the time frame. They're supposed to be 30 days minimum. And a couple of the MCOs are kind of dribble-drabbling out extensions every 2 weeks or something like that. But Jennifer Dudinsky at DMS was interested in hearing specifics about those as well. DMS has made it clear at the BH-TAC, and I'm sure this would be true across all provider types, that they don't want audits to interfere with the ability of providers to actually provide services. The audits are a necessary evil, perhaps, but should not either be so costly, as you've pointed out, Beth, or so demanding that they interfere with the ability to actually provide services.
Okay, thanks. And thanks for that information from WellCare and United Health. Okay, next up is Children's Health.
I don't think they have a representative on today, but they did have a meeting at the end of last month. They did not have a quorum.
Okay.
We're working on filling their inactive member slots so that they can have an active quorum.
Okay, thank you. Consumer rights and client needs.
I'm not seeing a representative on for them either today. They did have a meeting and they did have a quorum. They did not have any recommendations.
Okay. Dental?
Yes, the dental TAC met on November the 4th with a quorum. We met for about 2 hours, discussed a lot of topics, and just to highlight a couple was just we had a follow-up report on the oral health survey done by Dr. McKee. Several of the MCOs, for example, gave reports on the opioid prescriptions through dentistry that are actually decreasing. And Humana reported on a care transformation model, which is designed to help decrease emergency room visits. There was a C2578 study on the systemic complications of for Medicaid beneficiaries with type 2 diabetes. And it's another study that just kind of shows that, you know, what we put in our mouths and how we treat our mouths can affect the rest of our mouth. And it confirmed a lot of those aspects. There was a lot of questions about the new expansion program. And there are other questions on the administrative part that DMS said that they would be able to help us and handle that. But basically, we're looking at trying to help do things to minimize disease and to increase better oral health throughout the state so that Kentucky can get off the 49th level of oral health in the nation. But there was one topic that was brought up to me about that we might need to just look at in the future was on the patients in these substance abuse programs. That like when they go to the oral surgeon's office, it just takes an awful amount of time to coordinate them getting in the door and getting their paperwork, because then they've got to, the oral surgeon's office has to check on what's their status with their pain clinic. They got to be off their Suboxone, then they got to get back on. And they just talked about a lot of time it takes to get them medically prepared to do oral surgery on them. So that might be something we need to look at in the future. But there was no recommendations for the MAC, but we had a good TAC meeting.
Thank you. Okay, next up is EMS.
The EMS, excuse me, is our newest TAC. They did meet on the 24th for their very first meeting. So it was more of a, trying to find their way. They haven't, their next meeting on December 19th. And Beth, I misspoke. The consumer rights TAC did have recommendations, but they don't have anyone on the call to bring those forth. So I'll make sure to remind them in their next December meeting to bring those forth in January.
Okay, thank you. Health disparities. Home health.
This is Susan. I'm not sure Evan is on today. We did have a meeting. We did have a quorum. We had no new recommendations, but we are still waiting on follow-up from our previous recommendations. Thank you.
Okay. I'm a little bit confused here. On my previous agenda, I have nursing home care, but I don't see nursing home care.
They have postponed their meetings until March of next year, so I just removed it.
Okay.
Because they haven't been meeting the past few months.
Okay. All right. Thank you. It just threw me off a little bit. Okay. Hospital.
This is Russ Ronaldo, the hospital TAC. We did not have a meeting. Our next meeting is scheduled for the beginning of December.
Thank you. Intellectual and developmental disabilities. Nursing services.
Isn't intellectual and developmental disabilities a new one?
No, they had their meeting just a couple of days ago.
Yeah, Rick Crispin was on just a little while ago, and he.
Oh, I'm sorry, I was on mute. I'm sorry. Yes, we met on the 15th. We had a quorum, and everything I was going to cover has already been covered during the commissioner's presentation.
Okay, thank you. Okay, nursing services. Optometry.
Yes, Steve Compton from the Optometric TAC. We met November the 10th. We had a quorum, all the MCOs and subcontractors were present. We had discussion over the upcoming expanded benefits, but like dentistry, we're still waiting on some answers, and we have no recommendations.
Thank you. Persons returning to society from incarceration.
I believe they met. Steve Shannon had a conflict, and they're waiting for the SUD waiver to be approved to really get into some recommendations. So I don't believe they had any recommendations.
Okay, thank you.
Mm-hmm.
Pharmacy.
Sorry, I couldn't get myself unmuted. I don't believe the PTAC met since the last meeting.
Okay, thank you. Physician services?
This is Ashma Gupta. The physician TAC met on November 4th and we had quorum. We do have a recommendation. The physician TAC recommends that DMS consider the impacts of inflation and rising labor costs on providers and practices as it considers changes to the 2023 physician fee schedule. And further, the physician TAC recommends that DMS look at enhancing the highly utilized primary care centered codes 99203, 99204, and the codes between 99212 through 99215. I do have just a bit of an explanation, so please bear with me, but I think it will help explain the reasoning for our recommendation. In cross-comparing the 2022 fee schedule with the 2013 fee schedule, looking specifically at some of the more highly utilized primary care codes like 99203, 99204, 99213, and 99215, which are the E&M codes for new and established patients, there has not been a rate change for any of these codes for at least the last 9 years, if not longer. All the while, the rates for these codes in the Medicare space have seen a congregate average increase of 18.2% over the same time period. Currently, the Kentucky Medicaid fee schedule for these 4 aforementioned codes is about 66% of the Medicare rate. Meanwhile, at the same time, according to the U.S. Bureau of Labor Statistics, prices for medical care are 28.14% higher in 2022 versus 2013. And just over the last 2 years, prices for medical care are almost 5% higher. Physicians are the only Medicare provider not receiving an inflationary update in 2023. This is particularly destabilizing as physicians, many of whom are small business owners, contend with a wide range of shifting economic factors when determining their ability to provide care to Medicare beneficiaries. The same could be said for the state's Medicaid physician fee schedule, which is already significantly less when compared to Medicare. The cost effectiveness of primary care is well documented, going back to Barbara Starfield's paper, who demonstrated that healthcare systems which have more comprehensive primary care improve population health at lower costs and with greater equity. Primary care is the foundation of a high-functioning healthcare system. Evidence compiled over the past several years, both nationally and internationally, resulted in the conclusion that primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes, end quote. Investing in high-quality primary care is an essential component of multiple policy priorities for the state, including creating a more robust health workforce and ensuring that healthcare coverage translates into meaningful access to care. Thus, the physician TAC would recommend that as a first step towards enhancing its primary care investment and helping providers deal with inflation, that as DMS finalizes its 2023 physician fee schedule, it considers enhancing the rate for more highly utilized primary care codes that have not seen an increase in nearly a decade or more. And I did specifically say physician, and that's just because that's how the graph and research stated it, but this, I'm sure, applies to anyone who uses these, any healthcare provider that uses these codes. Thank you.
Thank you. Primary care.
Excuse me. My name is Lisa Lockhart from the nursing TAC, and I was having some trouble getting my phone off of mute when you called the nursing TAC. Would it be all right if I spoke briefly?
Yes, please.
Okay. We, the nursing TAC met, and we just wanted to bring forward, actually, or re-ask about a recommendation that we had brought to the MAC in the spring meeting. And let me just make sure, I just wanted to read exactly the way we had produced this. We had decided to take the reimbursement issues to the MAC, and we just wanted to recall the issues that we brought to you previously to see if there were any responses for us yet. The first was the recommendation that all APRNs in Kentucky be reimbursed by Medicaid at 100% of the physician fee schedule. Currently, it's at 75%. The MAC approved this recommendation and took it to DMS. DMS came back with a statement that they will look at it. We are just curious to know if it's still being considered and where does it stand now.
Okay, thank you. Do you have any other recommendations?
The second was the recommendation that CPMs, certified professional midwives, be recognized as providers eligible for reimbursement for their services by Medicaid. The MAC had approved this recommendation as well and taken it to DMS, and we were wondering if there was a response or any updates. That was it.
Okay, thank you. And if you were in the earlier part of the meeting, that the CPM issue has been on the agenda for probably over a year. And Deputy Commissioner Cecil said that right now they are not looking at changing that regulation, but we'll keep.
I must have missed that. Okay, thank you.
So, so as far as your first recommendation, we'll look to DMS responding to that and then their responses to the recommendations. Okay, anything else? Okay, thank you, Lisa.
Not from nursing, thank you.
Okay, primary care.
Good morning, this is Mike Caudle. I'm chairperson of primary care TAC. We met on Thursday, November the 3rd, and a quorum was established. At that time, we do have a recommendation to the MAC, and it concerns dental that Dr. Bobowski also discussed earlier. And that recommendation is the primary care TAC recommends to the MAC that the following requests be approved by the MAC and forwarded to the Secretary of Cabinet for Health and Family Services. That the Secretary convene public and dental stakeholders to study and make recommendations to improve oral health information and state dental policies related to population health, dental workforce, in-state dental graduate retention, dentist and dental auxiliary education, and Medicaid MCO contracts that support dental reimbursement, dentist participation in Medicaid, dental telehealth, and dental case management. In addition to that recommendation, we also discussed that DMS is preparing a crosswalk on SUD benefits at our request and coordinating that through the MCOs. And to that end, Ms. Cecil provided us a document based on the ASAM level of care for SUD services that are covered by Medicaid, and the other documents will be forthcoming, including specific information to each MCO as to what each of them covers. And to that extent, Anthem and WellCare have provided that requested information. I do not have a copy of anyone else having done so yet. We also updated on the provider signature regulation. If the MAC members will remember, FQHCs and rural health are treated differently in that the regulation requires them to close an encounter in 1 day as opposed to 3 days. And the department has taken that up, that is going through their process, and will be hopefully be presented in part of this next legislature coming up. We had a presentation, actually I had two, but one of the presentations was by Dr. Julie Richardson and Casey Bryant. Casey is executive director of Mama to Mamas, and it deals with doulas. Doulas are trained non-clinical professionals who provide continuous physical, emotional, and informational support to a pregnant person before, during, and after childbirth. There are very few health plans who covers the cost of doulas at this time. The presentation was looking for the ultimate end of that being reimbursed category by DMS. And at that time, a discussion took place. It was pointed out that even though there's a lot of benefits to that, that there would be problems where they're not required to be certified about being able to spend Medicaid money for that. Medicaid promised that they will research the way that other states are handling the funding of doulas, and we'll get back with the TAC on that. Our next meeting is January the 5th, 2023 at 10 a.m. And we establish meeting dates for the rest of the year of March the 2nd, May the 4th, July the 6th, September the 7th, and November the 2nd. And that's my report from the PC TAC, ma'am.
Thanks, Mike. Any questions?
Dr. Bobrowski has his hand raised.
Get unmuted here. Sorry. Dr. Mike, thank you for those comments. The dentistry is really looking at an access to care problem, getting folks into the dentist. And I know 2 or 3 of the TACs have mentioned the about wanting to get fee increases. Dentistry hasn't had an adult fee increase for 20 years. And that fee schedule was based off of a 1998 fee schedule. I just got a report this week that from 2017 to now, 2022, that the cost of dental offices just to operate has gone up 40% in those 5 years. And it's just getting hard to see patients and lose money on a lot of procedures that we normally would have done. But one other comment, Dr. Mike, on your doulas, I believe there's several of the MCOs that cover that as an added benefit here in Kentucky, but I'm not the expert on that division. So, but I did notice that several MCOs do cover that. Thank you.
This is Dr. Gupta. I just wanted to say one more thing about the fee schedule. You know, because Medicare also is a proposed, I think, 8.2% cut starting in 2023, unless Congress takes action. And for, you know, our small businesses, it's going to be much more difficult for us to be taking care of Medicaid and Medicare patients if that cut does occur. And, you know, we're all small businesses, and it's going to hurt the patients just as much as the providers with decreasing access to healthcare. So just, you know, it's so serious to not cut our fee schedule and actually, you know, increase it. I just wanted to leave it with that.
I know in our FQHC that we would be willing to employ another 4 to 6 dentists immediately if they were available.
Susan has her hand raised, Beth.
Okay, go ahead, Susan.
I just wanted to add comment about the reimbursement. Home health rates have not been adjusted in over 20 years as well. So, you know, I think that's something that DMS needs to look at across the board is, you know, we need fair compensation for the services that we provide across the board.
And I would just like to add to that regarding reimbursement, just to put it in a little bit of perspective for nurse practitioners for a level 2 visit, that would be a 99212. It's $23. So I think what Dr. Gupta is talking about is kind of scary, because when you think about it, most of the visits are level 2 or level 3 visits. A level 3 visit for a nurse practitioner is $35. And I think everybody can appreciate that you can't keep the lights on, you can't pay staff when you're reimbursed at $23 or $35 a visit. So just to add a little context there to what we're talking about. It's people aren't getting rich on those visit codes. Okay, I guess enough on that point.
Beth, if you don't mind, I'll add comment to that. I mean, it's really going to, potentially force providers out of the market, and then that leaves patients going on unserved. And for those that, try to do the right thing and take care of the Medicaid population, maybe there ought to be a safety net provider status or something that is provided to us for those that are willing to continue to see Medicaid patients.
This is Sheila Schuster. I tried to raise my hand, but I don't know that it was successful. We may take the prize for the longest period of no rate increase. Community mental health centers have not had a rate increase since 1999. And I agree with the comments that have been made, particularly in terms of some kind of status for the safety net providers, because that's what our CMHCs are, and many of you all fall in that category as well. It is really troublesome, and as you all know, there's an increased need for behavioral health services in all age groups, particularly with children due to COVID and so forth. So I wouldn't want to be in DMS's shoes, I guess, but I think we're all up against it for sure. Thank you.
So with this much discussion about reimbursement, I'm going to put that on the agenda for next time for just an update on what DMS is. I know you can't act quickly, but just your thoughts, the thoughts from DMS on that subject. Okay, last up is therapy services. Okay, well, that concludes the reports and recommendations from the TACs. Would somebody like to make a motion to accept those reports and recommendations?
So moved. This is Sheila Schuster.
Second, Susan Stewart.
Okay, any discussion? All in favor, say aye.
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 Anybody opposed? Okay, the reports have been accepted and the recommendations have been accepted. Moving on to new business. Mackenzie Wallace has volunteered to be nominated for secretary. I have not received any other self-nominations for that position. So it would be the pleasure of the MAC. Unless there's somebody else who would like to step forward, would somebody want to make a motion to accept Mackenzie Wallace's nomination as secretary?
This is Nina Eisner. I'll make that motion.
Kathy, I'll second.
Okay, Mackenzie, everybody is in favor of you.
Thank you all so much. I'm sorry I'm not on camera today. I'm traveling, but figured no one else stepped up, so I'm happy to do it.
Mm-hmm.
Okay, any discussion? All in favor, say aye.
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 Anybody opposed? Aye. Okay, thank you, Mackenzie. You are our new secretary. Any other business to come up?
Beth, Steve Shannon dropped in the chat. He's sorry for missing the re-entry TAC report, but they did not have any recommendations from their November 10th, 2022 meeting.
Okay, Steve, does he want to say anything?
I think he had multiple meetings going on this morning.
Yeah, I actually have
there you
3
are.
laptops going right now, tracking all stuff. The other, well, anyway, no, I have nothing else to add to that. We did not have a quorum. We had no recommendations. So,
Okay. Thank you,
thank
Steve.
you.
Okay.
Beth, I have an item under new business. This is Sheila Schuster.
Okay, go ahead, Sheila.
In addition to the rate issue, the reimbursement issues, I should say, the other common thread that I'm hearing from all of us, and I don't think we've had a discussion as a MAC about this, is workforce shortages. And I don't know what we can do about it, but it feels like the MAC is the one place where every kind of provider and every kind of Medicaid recipient has a meeting place and a place for discussion. And it just feels to me that that is such an important issue that we ought to at least put it on there and perhaps start with a question to Medicaid about what initiatives they're looking at, maybe what they're learning from other states about what other states might be doing, and looking at various workforce shortages.
Okay. Veronica, can we put that on the next agenda?
Sure. You know, I think this is where we do need more input engagement from you all and from your provider associations, from the boards, from the licensing boards. The workforce issue can't necessarily be solved by Medicaid. It has a lot to do with availability of practitioners, how many are graduating, how many are staying. There are, and I hear the conversation about rate increases. I promise you, we do continue to evaluate that. And I know a lot of providers think that's the solution to the workforce issue. If you just had more money, you could pay more and you could attract more people. But we're not seeing that as the I guess, the way to resolve the issue. I mean, you're still going to have, even if we raised everybody's rates, which we can't do because we don't have the budget for it. This is a legislative problem. We have to have the budget to increase rates. But you're still not going to have somebody to fill that position because they're not there. So, and a lot of you all are competing for the same workforce. So if we can't continue to increase each provider type to a point where you're still going to be in competition for that limited workforce. So we are happy to continue the conversation about this. And we've been working on the dental workforce issue, and we are committed to continue to look at that. But I get it's across all provider types. And what we need at the table are the licensing boards and the schools and the associations to come and work together. And it's not just Medicaid, to work together on those workforce challenges. I know the governor is trying to adopt a lot of policies to try to encourage increases in the workforce. So the challenges are beyond solutions that are just Medicaid. And I think we just need to keep that in mind.
I absolutely agree with you, Veronica. This is Sheila, and I wasn't intending that or implying that it was simply a Medicaid problem, but the MAC is the one place where so many of, in fact, nearly all of the health and health-related professions are represented. I would be happy, Beth, to take a few minutes at our next meeting to present an idea that Emily Beauregard and I have presented at the MOAC about the workforce issue, and it has to do with licensure board data, because we really don't know who's out there practicing because our licensure boards aren't asking the right questions. And we're looking at some legislation possibly in the next session, and I'm happy to present that to the MAC as at least a piece for people to look at, if that would be helpful.
Sure.
Those are wonderful things to bring up and have discussions about in this forum, but you just pointed out, Dr. Schuster, it will take legislation, it will take executive policy, it will take the licensing boards, you know, to really impact any of this. And certainly, you know, welcome to have this to be part of the forum in which that's discussed. But I wanted to temper expectations a little to,
absolutely,
you know, yeah, to make sure everyone understands what our limitations are.
Right.
I think
there
we do.
A number of go ahead, Beth.
I think we do understand that that DMS is limited and what they can do. But I think, to Sheila's point, this is one of the places where all of the healthcare providers come together. And so it would be a good place to kind of brainstorm and to bring information forward to perhaps formulate some type of legislation in the future. So I think this would be an appropriate place for those discussions to begin. And then the other point is to reimbursement. I think that none of us expect that the reimbursement for Medicaid is going to be raised at any time that's going to be competitive with some of the private insurances or even Medicare in some circumstances. So the idea is not to try to recruit new providers to Medicaid, but to prevent currently participating providers from dropping out because the reimbursement is so low. I think that would be a more realistic perspective on it. So at our next meeting, Sheila, if you would like to provide an update on that information, that would be great. And I'll put that on the agenda.
Yeah, and Emily Beauregard from the Consumer TAC, because this is a consumer issue as well, if you think about it. They know that if they can't find a provider, they're not going to get the service. So I'll volunteer Emily without her being here, that we'll do something on what we had presented at the POAC.
Okay, so let's look at maybe a 15 or 20 minute.
Yeah, we don't need any more than that. And there may be some other information that others want to bring to the discussion, but it would at least get it started, kicked off a little bit.
Yes, thank you for that.
Mm-hmm.
Okay, any other business that somebody'd like to bring forward or comments? Okay, our meeting dates for next year are posted. And just everybody take note that we're doing November a little bit differently. In past years, we've met before Thanksgiving, and for 2023, we will be meeting after Thanksgiving for that November meeting. Okay, if there's no other business, then would somebody like to make a motion to adjourn?
So moved.
Okay, Dr. Bobrowski, second.
Second, Sheila Schuster.
Second, Sheila. Any discussion? Okay, all in favor?
Aye.
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 Aye. Okay, thank you, everybody. We'll see you next year.
Happy Thanksgiving.
Bye.
Thank
Bye.
you. Bye-bye.
Happy Thanksgiving. Thanks.
Happy
Bye-bye.
Thanksgiving.
Happy Thanksgiving.